Of course, people use language to work together, and they need enough shared language so they're confident they're talking about the same things, building the same things, and measuring the same things. When people are inventing things like integrating behavioral health in the medical home, if they're doing it in their own settings, they just need good enough shared language among themselves. Next slide. For example, we know what we mean by that here, and that's good enough. But when you're coming together across settings and stakeholders, such as integrated behavioral health, what we mean by that here greatly enlarges. It's not just your own practice. It's a much larger group. In your Colorado project, it means all these stakeholders. Next slide. The practices, the health plans, the employers, the state agencies, the foundations, everybody. Without good enough shared language, it's very easy to misunderstand each other. Assume you're talking about the same thing, doing the same things, measuring the same things. And when you get into the middle of it, without enough shared language, it's easy to have experiences like this. For example, someone will explain their program, and a person sitting next to them say, well, we already do that. And then when you ask them what they're actually doing, the person says, well, I don't really think you're doing that. There's a different concepts of what things mean or what the functional requirements are to count as the real thing. And this kind of confusion can take up a great deal of time at meetings and lead to a great deal of head scratching. So here in the Colorado project, it's a question of what are the core functions for integrated behavioral health that we agree have to be in place? What words will we use to express them? What can be different from place to place, from one's practice to another, the local adaptation of it? Or even just terminology. For example, what's the difference between integration, collaboration, co-location, referral relationships, and so forth? How do we understand this so that we can get through a conversation without having to stop or backtrack as we misunderstood something with each other? The field has recognized this problem and this issue of language, and like many other emerging fields in science and in healthcare. So AHRQ, the Agency for Healthcare Research and Quality, which is the federal agency that does a lot of support for the development of a patient-centered medical home and research and implementation in that area. The AHRQ has supported the development of a consensus lexicon for integrated behavioral health in primary care. And some of your Colorado experts have helped develop it. So Dr. Miller and your Colorado planning group are well aware of the need for a good enough shared language for your Colorado work and are adapting the AHRQ lexicon to create the Colorado framework, which you've all seen. This framework is a guide to what to build, what to measure, and for practices to decide whether they have enough in place functionally to participate in it. And also it will point to where we need to put more in place to participate in it. So I'll give you a quick overview. Next slide, please. First of all, there's a what. What is this? So it's an ordinary two-sentence definition, okay? And then there's essential functions, sort of a how. A practice team tailored to the needs of each patient. And then that's described in some subclauses. So that the team is defined at the level of each patient, that there are shared operations and workflows, and there's enough formal or on-the-job training to do it. And then a shared population and mission. That is, you've got a group of patients you're jointly responsible for total health outcomes, the behavioral and the medical side, sort of a denominator. We know who we're working with together, and we have the same mission. And then what really is the heart of it is a systematic clinical approach. These are specified, like how do we identify people that need integrated behavioral health? How do we engage them? The presence of shared care plans where the medical and behavioral health parts are all together in an electronic record, and with systematic follow-up. Functions that you monitor in order to know if people are getting better, and you change the treatment where you need to. So that's a quick sense of the clinical how this framework has. And then, next slide please, there's also an organization, there's also a clinical execution checklist, like for example, do we have protocols in place? What level are they followed? Are there shared care plans? In what proportion of patients? The degree they're followed? And what is our level of systematic follow-up on these specified elements? This helps you see where are we with carrying it out, because it's one thing to have a vision for integrating behavioral health, and that's part of alignment, practice alignment with the Colorado vision for this, but also is the extent we can execute it reliably, the extent we can truly execute it. So the alignment of it has to do with both, are we trying to do the same things, and what's our level of execution of it? So next slide, please. There's also a set of organization checklists, because there are functions, organizational functions, that need to support the clinical ones. So for example, what's your level of office practice reliability and consistency? Does it happen every day really well, or is it on and off depending on the day, or it's like for a certain amount of the time it works well? What's the level of leadership alignment, and are we all really pointed the same way in the practice? What's the level of business model support, and the extent we use practice data to collect and improve? So those are also checklists, so execution checklists, you might say. Next slide, please. Also, the framework contains, or the lexicon in Agency for Healthcare Research and Quality contains a glossary. And these are just some of the headings. It's like a family tree of common terms, because people often get confused about, what do you mean? Is shared care the same as collaborative care? Is it patient-centered and integrated care? So these are all defined in reference to the literature. And so that when you want to find out what, are we talking about the same thing, you can go to that page as well. Next slide, please. The Colorado framework is a very nice self-contained thing, customized to the specific purposes you have in Colorado. But if anybody wants to back up and say, what was this, what's the Agency for Healthcare Research and Quality doing with the Academy for Integrating Behavioral Health and Primary Care? There's a lot of literature in there, a lot of other helps, a lot of other resources, including the full-bore lexicon from which the Colorado framework is adapted. So there's a screenshot for that. And if you want more specific information about this, you can go to the www.coloradosim.org website, or email Carissa Kinman at ucdenver.edu for more information on that. So thanks a lot for the chance to talk about the need for good enough shared language and the work the Colorado group is doing in that direction.